Hello, and thank you for joining our webinar, Updates in Telehealth Coding and Best Practices. Our presenter today is Suzanne Casimore, our Coding Director at MTBC, and I'm Seth Lunan. I work with the Telehealth Division as Chief Revenue Officer. I'm going to turn this presentation over to Suzanne, and with no further ado, take it away, Suzanne. Oh, I should mention a couple of housekeeping items. Everyone is on mute, except for the presenters. And if you want to ask a question, there's a lot of people on the webinar today. You go to your question bar and you enter it in text. We'll try to get to questions if we can at the end of the presentation. My apologies for that distraction. Suzanne, take it away.
Thank you, Seth. Hello, everyone. Good afternoon and welcome. And I thank you for coming. If I have any repeat offenders, should say, from I did a telehealth webinar not too long ago when Medicare came out with its first round of instructions, which is what I want to focus on today. There's a lot happening, obviously, out there. A lot of programs, a lot of changes happening day by day. So what I'd like to try and do is just sort of go through the simplest way for everyone to understand how to bill your telehealth services right now during this public health emergency with COVID-19. And hopefully the changes will slow down, but as you know, as we know, with this virus and with Medicare, changes happen sometimes frequently and rapidly. So as much as we can, we'll keep you updated as that goes. One thing I'd like to say is this information, again, is current. So these are the current CMS guidelines, and I do have some commercial carrier information, but again, it's current now, and as with everything, it's subject to change. Okay, so what I'd like to do is sort of give a recap. So on March 6th, Medicare came out with a bunch of guidelines, some how to code and how to bill them for telehealth services. Again, this is strictly Medicare. And one thing that they indicated was to use a place of service 02, no modifiers, established patients were only allowed. They did not have, they had a virtual visit code for telephones, etc. Go down the list. So there were on March 30th updates made addressing all of these issues I have here. Now, all of these changes were made March 3rd. They were published, I think, April 6th. But they're retroactive back to March 1st. So anything that was billed prior to this update can be resubmitted with the new place of service and codes, and Medicare will make the necessary adjustments and reimbursements, and we'll kind of go over that, especially with the place of service. And again, this is based on the interim final rule, which was published on April 6th. And I know nobody likes to read those final rules when they come out because they seem to be 1,000 pages of a lot of legal jargon. But actually, if you Google the interim final rule published on 4/6, you'll find it easy reading, and it'll have a lot of information, a lot of really good information for you in your practice of what CMS and what Medicare has available to you. Again, I'm just going over the basics for billing, so you may want to look into that. So first I want to talk about the place of service. So the place of service that Medicare originally indicated was 02 for telehealth when it first came out. They've since changed that to have everyone use the place of service where that visit would have normally taken place. So if the patient normally would have come to your office, whichever office it is, you're going to continue to bill in that manner. And the reason why they changed it is because if you use a place of service O2, they reimburse it at a facility rate, which is less than what it would have been if you had used your place of service of office. I think they were thinking ahead, and that's why all of these can be rebuilt back to the correct place of service, so you can, get those extra reimbursements that have been lower on the O2. So primary example is again office, so you would use place of service 11, just as if the patient was coming to see you in the office. That's the place of service that you should be using going forward for all of your Medicare telehealth telephone services. Okay, the next change is now they want to be able to track the services, so they want you to use a Modifier 95. Modifier 95 just indicates that an asynchronous audio video telecommunication system was utilized during that visit. It's really just a tracking modifier for you to put on your claims. So you would be using a place of service 11 and the modifier 95 for Medicare. Okay, another big change that they made in the original announcement, they were not allowing for new visits. Now they are allowing for all new visits in all areas, be it office, hospital, nursing home, assisted living. You can see and bill for new patient visits. They did include 80 additional services within the Medicare list of telehealth that's on their website. There is the location there on the website. It includes physical therapy, critical care services, all the hospital subsequent inpatient hospital services, behavioral health, group therapy, psychotherapies. So they included over 80 additional CPTs on that list. So if you're uncertain and you want to just verify, you can go onto the website, the Medicare website here with this link, and it will give you the CPT codes that they have approved for reimbursement. And again, the place of service, if you're doing a subsequent hospital visit and it is done, the patient's at the hospital and the doctor's at home, you're going to use the place of service of where the patient is. So the patient would be, it would be a 21, if it's an inpatient hospital. So that place of service would change based on where they're located. And Medicare has, again, when they first started, they were asking everyone to use a G2012 code for any telephone only calls, because a lot of Medicare patients do not have access to computers or smartphones, and so they only have a telephone. And since they're in isolation, their daughters and sons and relatives can't really just pop in and set it up for them. We're trying to keep them safe. So they did turn on reimbursement for these codes. These codes have always existed. Medicare has never reimbursed for them. And if you go into the Medicare fee schedule, there are fees listed for each one of these codes. The 99441, 99442, and 99443. Those are for your MDs, your nurse practitioners, PAs, anybody that's able to bill an E&M under their credentials. And it's, again, it's time-based, so you have 5 to 10 minutes, 11 to 20. There are also codes 98966, 98967, 98968, which are codes for any medical assistants or RNs that cannot bill an E&M to Medicare on their own, so they can utilize those codes. So that's a big change. Now, the documentation requirements have changed, and this is going to be especially useful in those new patient visits. Because as we all know, a new patient visit, you're required to document a level of history, a level of physical exam, and a level of medical decision making. And that's very difficult to get a higher level of physical examination when all you do is have a visual of the patient. So Medicare has enacted the coming out for 2021 for how E&M visits are now going to be, the documentation is going to be assessed for each level. And it's going to be based on either the level of medical decision making or based on time. Now, the level of medical decision making, the rules and the guidelines for that has not changed. So it's either going to be moderate, low, high, or straightforward medical decision making. And there's a worksheet for that, which you can find on the Medicare website, which I'm sure most of you are familiar with. And now there's the element of time. Now, time typically, when you're doing documentation requirements for visit levels now, more than 50% is required to be documented as counseling coordination of care. That piece has been taken out. So it's just straight time. It has nothing to do with counseling coordination of care, 50% of the visit. None of that holds true. It's just straight time. So if the doctor says, I spent 20 minutes on the phone with the patient, now they still have to document what they did. You know, they still want to document their history, and if they can, you know, physically, visually see anything, and their medical decision making. But if the medical decision making based on, you know, what the doctor can do winds up being low, but he spends 40 minutes on the phone with the patient, that 40 minutes should get him up to a higher level. So it's either one or the other, not the higher of the two. So it's either going to be based on, again, medical decision making or time. So that should really help assist in, you know, determining these levels, especially for the new patients with the physical exam barrier. And here's a website, a link here where you can find out what those typical times are that are associated with each of these office visits. So you can have that handy, and for the doctors, so they know, you know, what levels they should choose based on those times. Yeah, and again, they have to document the time. So that's really important. They don't have to document in time and out time if they, you know, if you so choose. You don't have to say I started at this time and I ended at this time. They can give just I spent 20 minutes. They don't have to do time in and time out. But there are other documentation requirements for the telehealth services in addition to, you know, the services that they provide. And I know we went over this, this hasn't changed, and we've gone over this in the previous webinar, but they should be getting consent from the patient. Verbal consent is fine. They don't have to have it in writing, just that the patient consents to having this service performed via telehealth. And that's enough for them to document that consent was received by the patient. They should give a statement of, you know, how the phone call was. Was it a phone call or was it a video call? They can, you know, they don't have to get, you don't have to get into the specifics of a Skype, but I mean, it would be easier just to differentiate between, was it just a phone call or was it a video phone call? You should indicate the location of the patient. Where was the patient when you had this call? And where was the provider? And the names of all the persons participating in their roles. You know, a lot of times there may be the caregivers there that are responding or helping, and their name should also be there, and you know, how they helped and what their role was in in the encounter. And again, down to the total time spent on the call with the patient. So the time should be for all the services, again, for telehealth, video calls, and for just phone calls. So this way, you can accurately code and get the accurate codes and reimbursements for the time that you're spending with the patients. Just to kind of go through again one more time, because some of these terms are being used interchangeably: telehealth, telemedicine, telephone, just to kind of clear up, make sure everyone's clear on the differences. A telehealth visit is one that uses audio video. So it's your video calls. And a telephone is just audio. So your e-visits are anything that has communication via patient portals or secured emails or texts. And that's always, patient initiated. And again, the virtual check-ins, they're still available to be used. If in fact, that is the case. But again, you do have the telephone E&M call codes now that can be utilized in lieu of those virtual check-in codes. So down to it, how do we really, code this and get this to Medicare so that it gets reimbursed and it gets reimbursed properly? So as you see, for telehealth, the codes that you would use are your regular E&M CPT codes. All right, all of this is just an example of as if, the place of service's office. The place of service, again, is where it would have normally been performed, wherever the patient is, or where the patient would have been had we not been in this crisis. So assuming that's the office, which is the majority of these visits, you would use the place of service 11. And some of you have multiple offices, so you can use any of those locations. If they typically go to your Paramus office, then you use the address of the Paramus office. And you would add a modifier 95 to that CPT code. Now that's for telehealth, that's for your video calls. Your telephone calls, where it's just audio, you're going to use your 441 to 443. Again, this is strictly based on time. The place of service is going to be, again, the location where they normally would have been. Now, a lot of telephone calls are, most likely the assumption is that they would have been an office visit, and they just don't have the video. So you're going to use place of service 11. Modifier is not needed. They don't typically reimburse for these codes, so they already know that if these codes have been reimbursed for, it is a telemedicine service. You have your e-visits. Again, you have your codes there. The place of service, again, would be office, because the doctor is typically going to be answering these types of calls in his office or her office. And then the modifier, there is no modifier. And again, the same for the virtual check-ins, assuming that those calls are coming in. G2012 in the store and forward, which is the G2010 code. The place of service is 11, and again, no modifier. So that's a handy little grid for you to utilize for your Medicare patients on, where do I and how do I fill these out. Now, Medicare, even though they changed a lot of their requirements. Everything's very straightforward and fairly uniform in how they want you to reimburse and bill. Now, that unfortunately is not the case with commercial carriers or your Medicaid plans. And some Medicaid plans are based on commercial carriers in some states. So there is some differences there. So I kind of want to go through that again. Keep in mind that a lot of the commercial carriers, they're changing frequently, or they have changed as well. Some of them have changed in line with CMS. They may have been, again, using the 02 and now using 11. Well, some commercial carriers are not reimbursing for telehealth services for all patients. You really need to verify that the patient has the telehealth benefit and whether that carrier is requiring the patients to have telehealth benefits, because that is one of the benefits in the patient policies. So you really want to be careful to make sure that the carriers are reimbursing for all of their insureds, not just the ones with telehealth benefits. So you might want to, give them a call. And again, there is a great website that has a lot of commercial carrier information, Medicare information, and Medicaid information, the Center for Connected Health Policy. It's a wonderful website. Take a look at it. They keep it updated. It's got a lot of good information in it. Again, so that's the same for Medicaid. Medicaid, those rules could significantly change and be different from Medicare. I know we all think of Centers for Medicare and Medicaid, and they are supposed to be following the same rules, but they are not. Medicare is federal, and so they are following the federal guidelines with the president's direction and CMS. CMS is indicating that the states, which is where the Medicaid programs are, they are governing their own and making their own decisions. So you really need to check with your state Medicaid program as to how they want it billed. So to assume a Medicaid state, Medicaid billing is the same as Medicare is not accurate. You really need to go onto your state and find out exactly how they want it to be billed. Unfortunately, the same things with Blue Cross. Blue Cross Blue Shield, each of those companies are independently operated, whereas they've indicated that they are going to reimburse for telehealth. They're each governing their own rules in billing and again in who they're going to cover for the telehealth. But what I do have for you is some of the larger insurances, such as Aetna. Aetna has their billing, their commercial plans plus their Medicare Advantage plans. For telehealth, they're following essentially the Medicare guidelines. So telehealth, you use the office visit, place of services 11 with a modifier 95. Telephone, if it's done audio only, they want the telephone codes, place of service 11, no modifier. Again, same thing with the e-visits, the virtual check-ins, the place of service where it normally would have been taken place, which would have been the office for the doctors, and then, no modifier for Aetna. Now, Cigna is different. Cigna is reimbursing the CPT codes or the regular E&M codes for both telehealth audio, video calls and just audio calls. So they're doing it either way. And they have the place of service 11, and they're requiring a modifier GQ. It's just their way of tracking that it was telehealth, and they're using the modifier GQ in lieu of modifier 95. It's just their individual preference. They don't cover, I haven't seen any coverage information on e-visit codes, and they are covering for that virtual check-in code, again, the G2012 without a modifier. In United Healthcare, their commercial and Medicare Advantage plans, they also are utilizing office visits for both, for telehealth and for the telephone. The place of service is 11, and they want the modifier 95 on both. So whether it was telehealth or telephone, it makes no difference to them, apparently, and with the billing. So you can put the modifier 95. E-visits, they're reimbursing. Virtual check-in codes, they're reimbursing. Place of service and without any modifiers. Now, those are our big and our 3 or 4. I can't give you the Blue Cross again because Blue Cross, you really kind of have to check your individual states, but this should help everyone sort of get their bearings with most of their carriers that they're seeing their patients for. So that is what I have to kind of go over, the changes in some of the commercial carrier information. So I'm going to take it back to Seth to see if we have any questions.
Hey, Suzanne. Yes, thank you. And we do have some questions ramped up. We're going to try to get through some of these. So the first question in queue is a patient had a telehealth visit with a doctor today. The doctor asked the patient to schedule another follow-up telehealth visit in 2 weeks. And is this appropriate?
Okay, that's a good question. I think everyone's a little leery about, telehealth and not having them face-to-face and how frequency limitations and such. One thing I can say is that if the visit is medically necessary, by all means, schedule that visit for that next telehealth call. If this is something that is needed for the patient's continuity of care, then of course you should be scheduling them for another visit in 2 weeks. Certainly, if it isn't necessary for another 3 months, then you can schedule them for that visit in the next 3 months. But frequency, there really have, especially CMS has gone back on there are frequency limitations a lot of skilled nursing facility visits, of subsequent hospital visits. They've taken all of those restrictions off. So frequency limitations have been removed from any visits because they want to make sure that these patients are getting the care that they need. And some patients may be fine one day and then, need the care within 2 days or 3 days in some of these facilities where they normally would have people in-house that could help them. And those services, that's not available to them. So whatever is medically appropriate, you should go forward with.
Okay. This is not a question, but I just wanted to tell everyone that on your control bar, there is a handout, which is the PDF of the coding updates. And I will answer one, it's actually several questions. Several of you have asked if the slideshow is available. I will make sure that you have availability or email it to you if you're registered and attended. Sue, the next question is, can a physician do telemedicine from his or her home?
Oh, yes, absolutely. The assumption is that most of the providers are going to be providing these services to these patients at home. Most providers are not, most offices are closed or open, to a limited capacity and time. So yes, that is where they should be and can be performing the services. Just make sure to document that in the note, but it shouldn't change the place of service. The place of service should still be where the patient would have normally been had we not been in this emergency situation.
Okay, the next question. What about the code Q3014? Do we need to add that to telemedicine?
Okay, that code Q3014 is a telehealth originating site facility fee. And that code was created by Medicare to give the originating site, which is where the patient would be, a facility fee for using their equipment and setting up calls with the provider, with the distance site, which is the provider. So with that, in that respect, it's not a provider code. So the provider would not be getting that facility fee. It would be for the originating site. So again, typically patients would go to another doctor's office or a hospital or a skilled nursing facility, they would be there, and then they would have a telehealth service with a consulting doctor. And so that originating site where that patient is would be able to bill for that facility fee. So that would not take effect in this situation. And especially since Medicare is reimbursing with the place of service 11, so they're reimbursing as if the patients are still going into your office, you're getting those higher reimbursements. So that would kind of negate the need for even a facility fee in that situation.
Okay, we have many more. Do you have some time for a few more?
Sure, I can see what I can answer, absolutely.
Sure. So for the next one up is for the nurse visit telephone call codes. Whose NPI would one bill under? The doctor that he or she works under?
Yes, for if it's an RN or an ME that's making the phone call for those 989 codes, yeah, you would have to bill under the supervising provider or the provider's NPI number. You just want to, make sure it's documented who actually did the service, because you wouldn't be able to bill under that nurse because they're not credentialed. So you would bill it under the supervising provider or whatever provider you have available that's still seeing patients there for the practice.
Okay, next question. For the location of the provider, what do we need to put in? Place of service is 11 and location home office?
Yeah, the place of service that you're billing is not the same as where the provider is. Those two are completely separate. So you want to think of it as you're documenting where the provider was. So if the provider was in his home office, you can just say provider was at home. You don't have to give his address. That doesn't have to be documented. None of that information. You just say provider was at home, patient was at home. It's just to know where all the parties were at the time that this call happened. It's just a lot of documentation. But when it comes to billing, that is irrelevant. It's what you have to think of. Okay, so this patient, Joe Smith, always comes to our office and has his visits. So that's where you would use the place of service office, and you would use the office code. Now, I have some practitioners that they don't have an office. They always go to the patient's homes, or they go to assisted living facilities and they see the patients in their assisted living facilities. So you would use that place of service. So if you would typically go to the patient's home, and that's normal, where you would see this patient, you would use the place of service home, and you would use the home visit E&M codes. So it's really like back to you would code business as usual, where you would have normally scheduled this patient to be seen by the doctor, and you use that place of service in that location.
Okay, next up, some of these are specific to states and to particular payers, so I don't know. We'll ask the questions, and if we can address them online, then we'll get back to you individually. This question, please let us know if the rules apply to the NH telehealth visits. I assume that's New Hampshire.
Or is it nursing home?
Nursing home, I apologize.
Yeah, no, that's okay, because we usually, we'll use either NH or SN, SNF or NF. If it's nursing home, yes. So most of our nursing homes are in lockdown. So they're not letting the doctors in to see the patients. So it's just the staff that's in there, or the doctor can't get there for whatever reason. As long as that a telehealth service can be provided, you would use that location, that facility or place of service. They're in the nursing home, so you're going to use that place of service. and the telehealth service would then be provided while they're in there. And like I said, Medicare has eased off on the restrictions for frequency, number of visits, due to, the isolation and, the access to care. They may not have the access that they're used to, with providers being there consistently. And if it's the other side, if it's New Hampshire, I don't know that answer, so I apologize. But there is like I said, there's a wonderful website on, I don't recall which slide it is, but they have a lot of information about the different states, and it'll have links to Medicare. So if it's New Hampshire, they'll have that information on there for you.
Next question, Suzanne. What about Cigna Medicare Advantage plans? Do they bill the same as Aetna?
The Cigna Medicare Advantage plans, from my research on Cigna, those requirements were across the board for all Cigna funded plans. You can, Aetna and United Healthcare, they're both with the Medicare Advantage. So I would follow the Cigna Medicare Advantage, but if you can just give a quick call for one of your Cigna Advantage patients, give a call to them, and just to verify the billing there. They should have that information for you with a quick phone call.
Okay. Next question. Did you see the new release from Medicare saying to use the modifier CR?
Well, yes, that has to do strictly with COVID-19 confirmations and visits. And I don't really have that information. I didn't really go into that information here on this particular webinar. But the CR modifier is, they're requesting that for cost sharing too, because Medicare will reimburse 100% of their allowable. It's typically when you submit to Medicare, you get 80% of the allowable, and the 20% is co-insurance due from the patient. If the visit is directly related to a diagnosis of COVID-19, the visit or the testing, you can add the modifier CR, and Medicare is claiming to then pick up that 20% and pay you at 100% of the visit, of the allowed amount, rather than what is normal and customary. You can find more of that information on the website, but if you're interested, I can send you a link. You can just put your information on there, and after the webinar, I could send you a link to get all that information on the CR modifier.
Thank you. Next question. This says, do we have to use any specific technology, software, or device for telehealth services?
Okay, that's a good question, because there's been a lot of requirements and non-requirements, and so I'm sure there's a lot of confusion as to what's allowed. They are, Medicare is allowing for most programs that have the audio video capability and that are not, group sessions, I guess, if you will. They'll allow, for example, they'll allow Apple FaceTime, they will allow Skype, whereas normally they would not have. So any of those types of programs, Zoom is okay to use. So mostly, as long as you're able to do real-time synchronous audio and video, it's permitted for a telehealth service.
Okay, we have a couple more. When should we use code 02 telehealth as a location?
The only time that you're going to use that is if it's a true original telehealth type of service. The O2 place of service for Medicare, at least, is going to be giving you a reimbursement again at a facility level. So it will be less than you would have normally received had it been in, whatever location you are. For Medicare, I would say in this new PHE, you shouldn't need to use O2. You should just be using place of service as normal. If your services, if you've been doing telehealth for Medicare and you know the guidelines, the original guidelines of telehealth, and you have always used an O2 for those types of services, then I would say you should continue utilizing it in that. I have seen O2 being required for some commercial carriers. I believe it's Empire, Blue Cross Blue Shield is requesting the O2. Some Medicaid states may be. But for the most part, you really have to, for Medicare, you should be using the place of service that you would normally have seen or are seeing the patient in.
Okay, maybe one or two more, Sue.
Sure.
Can you charge for documentation for notes?
Can you charge for documentation for notes? I'm not truly clear on that question. If it's something that is billable, that was billable prior to our emergency situation, so if it's something that you've normally billed for, if the patient came face to face, then I would suggest, looking at that and following those, things that you have done in the past. But if it's something new, again, I'm not really sure exactly what documentation it is that you would be billing someone for. So if you wanted to send an email, there's an email here and kind of explain that a little better, I'd be happy to answer that.
Okay, let's do one more. First of all, the NH referred to nursing home. Thanks for clarifying that. Not New Hampshire, my mistake. But let's do one more, and then there's way too many. The rest of them will be addressed offline directly. So thank you, everybody, for submitting your questions. This last question is regarding how you handle dialysis center visits.
I think that one, Seth, we're going to use that one as well for something. I will email a response to that.
Yeah, I think there's multiple questions in there, so I think that'll be good. And then last but not least, please confirm that the time spent with the patient with telemed needs to be documented on all services.
Yes, it should be, especially since the requirements have been changed a bit, especially for Medicare, where you can code based on the time specifically. If you want the documentation to be based on history and physical exam and medical decision making, those levels can certainly be documented and established based for the telehealth services that you're using the office visits for example. But if it's a telephone call, so if you're doing a telephone call, it's a time-based code. And if you don't indicate a time on there, the only recourse that you would have would to bill the lowest level. So the 99441, a 5 or 10 minute call would have to be coded because there is no time listed on there. So it is in the best interest to indicate the time for every one of those visits.
Okay, there, as I said, many more questions we're going to answer offline individually. I want to thank everybody for attending our webinar. I will make a copy of this available to folks to download or send an email. I will certainly notify you after this webinar. Thank you, everybody, and thank you, Suzanne, for your wonderful presentation.
Thank you, Seth. Thank you all. Have a great evening.
Bye now.